My name is Pietro Michelucci, and I lead the Human Computation Institute, where we develop crowd-powered systems to tackle societal problems. For example, we created an online game called Stall Catchers that now has 30,000 players, speeding up Cornell University's Alzheimer's disease research. So when COVID-19 emerged, we started to brainstorm about whether we could somehow apply these same methods to reducing the impacts of the pandemic, and we came up with an exciting idea. When social distancing, where can people still get infected? At the store, right? So we had this idea that when lots of people all go to the same store, the infection risk is higher. And if we could evenly spread people out across stores, maybe we could reduce virus transmission. So we did some napkin math to see if the numbers work out. If you take 9 people and put them all in the same store, each person is exposed to 8 people, each of whom could already be infected with COVID. So that's 72 different ways that infection could spread. But what if you had 3 stores and you could distribute those same 9 people so that there were only 3 people at each store? Then each person would be exposed to only 2 other people. This adds up to 6 ways infection could spread in each store, or 18 total infection opportunities. So spreading people out evenly resulted in 4 times fewer infection opportunities. The napkin math confirmed our intuition. But the next question was, how do we get people to actually do that? We realized that, given the option, some people might choose to reduce their infection risk by going to a less crowded store. And the easiest way to provide that information might be on a navigation app, such as Google Maps, where people could see infection risk color-coded directly on the map as green, yellow, or red to indicate the crowdedness of each store. By this time, we had a tantalizing idea and a possible way to make it work, but we were also mindful of the Hippocratic Oath, first, do no harm, because we know from experience that even with the best of intentions, things do not always work out the way we expect them to. There can be unintended side effects and feedback loops that only show up when a system is deployed into the real world. So before unleashing CrowdMeter, we want to understand if there are circumstances in which it can cause more harm than good, or in what situations it will be most effective, and then use those findings to inform our specific design to ensure CrowdMeter is built and used in only beneficial ways. For example, if only a fraction of people are using the app, it could really help them, but if everyone uses the app, it could backfire. If they all rush to the safest store, then it suddenly becomes the most dangerous store, and everyone there gets infected. To make things trickier, this situation could arise due to a feedback loop. If the media reports on rising infection rates, we could see a sudden increase in CrowdMeter adoption, possibly creating this kind of overload situation. So how do we figure out how to do no harm without putting people at risk in the process? As a start, we run simulations, which are basically computerized mock-ups of the real world that capture the important parts of what we want to understand. There are many COVID simulators already out there, but our simulations are more complex and have unique requirements because we are trying to understand what happens when you introduce an online app that impacts many different systems that are affecting each other. So we have a model of human decision-making behavior that balances risk aversion against the burden of traveling farther, a model of the virus, a model of disease spread, a population flow model of human movements, and a model of how the CrowdMeter app would work. But simulations are only as good as their underlying assumptions, garbage in, garbage out. So we gathered a team of specialists to help ensure that these 5 interacting models approximate real-world conditions. With kind support from Aspen Tech Policy Hub and a donation of Azure Cloud Computing time from Microsoft, we built a CrowdMeter simulator to help us test and refine the CrowdMeter concept before we go live. This is what the simulator looks like. This grid represents a hypothetical town. The 3 big dots are grocery stores, where the color of the store tells how crowded it is. The tiny dots are people. Green people are healthy and red people are infected. And any dot with a black outline is a simulated person using the CrowdMeter app. Since our main goal is to flatten the curve, the first question we ask the simulator is whether or not CrowdMeter can actually do that. Flattening the curve does not necessarily mean reducing the overall number of people who eventually get infected by COVID. It means to slow down the infection rate so that our healthcare system does not get overloaded and people who get COVID can have better outcomes. Until we have a vaccine, this is our best option, and even with vaccines, it can still help. So we ran our simulator with a range of CrowdMeter adoption levels. The first thing we noticed is that with more people using CrowdMeter, we were actually seeing a more even distribution of people going to different stores, which is exactly what we'd hoped for. Next, we looked to see if the curve got flatter when people were more evenly spread out over stores. We were quite surprised to discover that it didn't. We soon realized that our initial assumption of 10,000 people sharing only 3 grocery stores resulted in a very high person density at all 3 stores all the time. This meant that even when people went to the safest store, they were almost certain to become infected. So in that circumstance, using CrowdMeter to distribute people evenly across stores gave no advantages. When we adjusted the population size in our simulator to real-world values, about 1,000 people per grocery store, we saw exactly the kind of curve flattening we expected. CrowdMeter was working. So the next question was, is there such a thing as too much CrowdMeter? We ran some simulations at very high adoption rates and discovered that infection rates do start to go back up, which made us realize that there could be such a thing as a CrowdMeter overdose, where adoption levels could get so high that we start to see an opposite or paradoxical effect. We thought that the reason this happens is that there is a travel delay between when people decide to go to a store and when they finally arrive, and then the situation can be different than what they expected when they get there. This made us wonder how data latency, the freshness of CrowdMeter information, can impact how well CrowdMeter works. This is important because the population flow data sources available to us are not perfectly real-time. There are some delays. So we decided to test this explicitly by looking at different levels of data freshness to see if CrowdMeter could still be helpful even if the data were not perfectly real-time, but instead near real-time. For example, what happens if the CrowdMeter data is 15 minutes old or 30 minutes old? How does that impact the flattening of the curve? And we discovered that with moderate data delays, CrowdMeter could still be helpful, but beyond about 45 minutes of delay, it could actually increase infection rates. Observing in our simulations that the combination of high adoption levels and data delays could actually make things worse, we set out to examine the full space of those conditions to get a better sense of where CrowdMeter would likely be helpful or harmful. This set of simulations revealed a safety zone, which is depicted in green, and a danger zone, depicted in red, for operating CrowdMeter. All of these simulations so far were based on COVID, but we hope that CrowdMeter could be used in the future to help attenuate the spread of other viruses, such as influenza. But each kind of virus has its own characteristics, so we set out to also simulate the impacts of CrowdMeter on viruses with different levels of infectiousness, and discovered that for COVID and influenza, it could be most effective, and possibly for the common cold. But for highly infectious diseases like the measles, even CrowdMeter cannot contain the spread. Situations like that will require strict quarantines. So what do all these findings mean? We learned that CrowdMeter, like any intervention, has a therapeutic range. For example, antidepressants can actually worsen depression at the wrong dose. Similarly, if we think of CrowdMeter like an anti-pandemic pill, we have observed a similar paradoxical effect where increased adoption is beneficial up to a certain point, after which it can actually cause harm when data delays are present. We also learned that under certain extreme conditions, CrowdMeter would not help at all. For example, when there is either an unusually high ratio of people to grocery stores, for example if half the grocers shut down, or when the virus is highly infectious, such as with the measles. But the good news we discovered is that for the current virus, COVID-19, and the typical conditions found in most places, CrowdMeter will indeed flatten the curve. So what's next? That green area in the final graph represents CrowdMeter's therapeutic range. So our next step is to release a pilot version of this app in a context that falls within the safe green area of that graph, with participants who voluntarily and knowingly agree to contact tracing, so we can test our assumptions and simulation outcomes against a real-world implementation. We will then use those results to fine-tune CrowdMeter before releasing it into the wild. We also intend to run new simulations to test if CrowdMeter can be even more effective by evenly distributing store visits not only between stores, but also at the same store over different times of the day, and even use artificial intelligence to predict population flow to make that work even better.